Prynhawn dda, a chroeso I chi gyd. Good afternoon and welcome to you all. My name is Kieran Humphreys. I'm a consultant in public health with Public Health Wales, and I oversee the wider Determinants of Health unit, which hosts a Public Health Network Cymru. I'm absolutely delighted to be here for our first Public Health Network Cymru webinar. Today we have two speakers joining us, Jan Williams and Chris Williams, followed by a question and answer session for both. And I'll start off with just a few housekeeping points. If we could ask you all to put your microphones and cameras off. The event is going to be recorded and we want to make this available on our website. This is our first webinar, so please do bear with us. If there are any hiccups, we hope to resolve them quickly. We've got technical people on standby to help us with that. And also, as part of the setup here, we've got a few features I'd like to point out. One is you'll see three dots in your little bar. If you click on that, you'll have the option to look at captions, which are live, and they can be chosen in Welsh. So if you want to choose that, we'd love your feedback on how you find that. And in the bar, you'll be able to give a question and answers for our speakers. There's just a little question mark symbol you'll see there. Click on that and send through whatever questions you want for Jan or Chris, and I'll be asking them later. So we've really pleased that we've got Dr. Chris Williams here today. He is a consultant epidemiologist. He's had a leading role with the European Programme for International Epidemiology Training and is a principal investigator for Public Health Wales for the Oxford Trial Group COVID vaccine. But before we get into the world of all things COVID, I'm going to hand over to Jan Williams, who is the Chair of Public Health Wales. She has previously been the Independent Police and Crime Commissioner for Wales, Cheshire and Mersey, and she also holds an OBE for services to the Health Service. Really delighted to have you here, Jan, and it's over to you.
Diolch, Kieran. Prynhawn da, gyfeillion, chroeso cynnes i'n webinar COVID-19 yn Grano. Warm welcome everyone, good afternoon, and I'm delighted to be introducing this COVID-19 in a nutshell webinar. This is coming to us under the auspices of the Public Health Network Cymru, which formed in 2015, bringing together 4 previous networks. And the network is in fact going from strength to strength. There are over 1,500 members from academia, the NHS, local government, the third sector, and of course ourselves in Public Health Wales. All are represented here today. I'm delighted that so many of you have been able to join us, and I do hope that those of you who are not members will feel encouraged to join by the end of our series. The network is very active, as members will know, and this idea for the webinar series came from the team, who, in addition to fully supporting the Public Health Wales COVID-19 response, have been thinking of really creative ways to support members during COVID and to take advantage of the accelerated move to a digital world. So, diolch o galon i'r team. Thank you very much to the team. And of course, we do know that COVID-19 represents a global public health emergency that none of us have ever experienced in our lifetimes. And it's described as a syndemic, because it's co-occurring with and it's exacerbating existing inequalities, and it's exposed and worsened many of the underlying inequalities and health-related consequences. And of course, we are moving through waves of impact. The focus so far has been on the first wave, the immediate mortality, morbidity, and controlling the spread of infection. But as we're moving through into the next wave, we're thinking about increases in mental ill health, unemployment, educational impacts, and all of these will have severe consequences for health unless we tackle them. And one of the biggest issues we need to tackle is the impact of unemployment on health and well-being. A rise in unemployment of even up to 7% could increase levels of long-standing illness, mental ill health and other conditions by about a third more again in 3 years from a 2019 baseline. And our responses to COVID have to be considered in association with other major imminent pressures on health and well-being, Brexit, climate change and sustainability. And we must make sure that we don't just consume the health of future generations to protect the health of current ones. And that's described as the triple challenge facing us. We've got a great opportunity to build better coming out of COVID, to maintain some of the areas of gain that we've made, reduced pollution levels, for example, better work-life balance through home working, better use of IT and social media, of which today is a really key example, to keep connected with ourselves and to accelerate the digitalisation of services. But today is all about understanding COVID in a nutshell, and we could have no one better to do that for us than Chris Williams. So gobeithio I cewch chi ein webinar yn ddiddorol ac yn ddefnyddiol, and dwi'n falch o gyflwyno Chris Williams. So I'm really hopeful that you'll find our webinar both interesting and informative. I'm sure you will. And I'm delighted now to hand over to Chris Williams. Drosoch I chi, Chris.
Okay, diolch Jan. Prynhawn da. I'm afraid that's the end of my good afternoons, but welcome to this webinar. I'm now going to start sharing my screen, which I hope will work. I don't know if I get any feedback as to whether people can actually see that or not. I think it is. So I will proceed as if people can see it, and if they can't, then I will expect some kind of message frantically telling me that that's not really working. Thanks so much for the kind welcome, both Jan and Kieran. So I'm going to just try and take you through a bit of the epidemiology and just a little bit of the phases of my experience from this, because for me, very personally, this has been going on right from the first day I came back from Christmas holidays on January the 4th. There was this, there's another teleconference Public Health England are holding, there's something going on in China. So that's how it all started, and this has been a sort of daily thing for the team since about then, to be honest. So I just started with a preamble of, I know it sounds tight, but we do this all the time. Not a huge pandemic like this is unprecedented, but the country, the world has been through large waves of awful diseases before, and there's always someone who has to count them, and that's our team, with the help from enormous numbers of people. So this is comparing a 1894 report on the sanitary condition of Merthyr, of which you can see at least one really nasty former global pandemic, smallpox, in there, with fortunately only one case in Dowlais there, but clearly lots of other infections. And our current local authority table, whilst we've adjusted by population, doesn't look so different that I don't think that there's a certain amount of continuity there. So it's one of the things I like about epidemiology, is I feel that we're carrying on something that's been going on since people could first count, really. And the other thing to say is we're always having, you know, these unexpected, huge emerging disease threats that only happen once in a generation. Well, apart from that one last year, and apart from the one the year before that. So actually, this is, again, unprecedented, but we do get big stuff coming on quite a lot. This is the worst I've seen, but it's not the only one. So there was SARS in #1 in 2003, swine flu in 2009, and that was a big response. I was part of that. Ebola was confined to a few countries, but it was a huge response, and a lot of local epidemiology and some similar issues, actually. And then in between that, we have the smaller ones like Middle East associated respiratory syndrome, coronavirus, MERS-CoV. We had a monkeypox incident that had only just finished when this one started. So we almost segued in from the same people to this infection. And of course, every year we have influenza, we have seasonal coronaviruses, RSV, other things. So I'm not to downplay this, but this is, this is within the realms of sort of what we do. It's just been particularly awful because of the severe consequences and the very rapid spread. And this is an example of the flu season. So you can see every year, you can see the big one in 1999-2000 that really hammered the NHS. You can see the swine flu one in 9-10, and you can also see the big year we had in 2017-18, which was associated with quite a significant impact on the health, particularly of older people, once again. And this summarises, I'm just putting this as a, the influenza season is also coming, possibly at the same time as the next COVID wave, just to remind you that, we had 192 patients in intensive care with influenza in that season, which is of the same order of magnitude, actually, of the numbers we've had overall with COVID over this season. That's not to say that those are there just because of influenza, but, there is a significant impact. Obviously, COVID could have done much more than this, but I just wanted a reminder that there are other infections that have an impact. And also the vaccine is a focus within influenza. So I'll do a little bit about coronavirus epidemiology. So the first bullet point, I kind of elide past some really huge issues that you'll hear all in the news at the moment. Is it airborne? Is it not airborne? Do you wear a mask? If you wear a mask, will that stop it? I'm an epidemiologist. I take a rather simpler view than maybe my much more qualified virological colleagues who will know about particle flows and sizes of droplets and that kind of thing. What I'm interested in really is, do people actually get infected and in what settings? Whether that's explainable through looking at particles is very interesting, but it doesn't really tell you what happens in the real world. So I would probably characterize it that this is a droplet infection like meningitis or something, but there was some airborne potential, as with a lot of things. So if you put it in a setting where you can generate small particles, where it's a closed setting where people are talking to each other or singing or whatever, then yes, it can spread and waft a bit further than you'd expect, and probably further than 2 meters. None of these things are absolutes. We've also seen pre-symptomatic transmission, which we'd really hoped at the beginning wasn't true, and then rapidly or slowly became aware that actually was happening. As with all these things and flu, you get transmission in hospitals and other closed settings. This is nothing new. It just took us longer than I think we should have required to work that one out as to exactly what the impact would be. The symptoms are very variable, and I'll mention the case definition later, but anosmia started off as a rumour and very rapidly came into the national case definition. That was quite interesting from our point of view. Hardly anybody's immune to this. Latest estimates are around sort of 6% is what I've seen, or that's not fully published yet, but that's nothing like enough to keep the population safe. Incubation takes about 4 days. It can be pretty quick, can be as much as 14 days. Initial estimates about 4% hospitalised. I may revise that down, and it's highly age specific. The mortality is still holding about 1%. I've done some recent estimates. It still looks just under or just over 1%, but very sharply influenced by age. And it's a systemic disease. Again, I'm not going to go into the clinical details, but there's increasing evidence that this ACE2 receptor is on the linings of blood vessels on the endothelium, and therefore it can really do damage to lots of different body systems, causing clots, causing dysfunction all over the place, neurological, lung problems, heart problems. It's a really nasty infection. And when I've talked to clinicians from ICU, some of which I've met through the study, that's been a real focus for them. And it really doesn't look that much like SARS-CoV-1. It doesn't look so much like influenza, and it doesn't look like measles. So it is quite new. So what are the symptoms? So I think everybody on this call could probably reel off, I'll probably get it wrong now, cough, loss of taste or smell, fever, etc., shortness of breath. The bit on the left is a YouGov poll showing that lots of people know that coughs is associated. Well, I think there's still only 87% said cough, but only 58% of them know all of the case definition symptoms. And when you look on the right, I looked at the Centre for Evidence-Based Medicine. There's a link at the bottom about symptoms and reviewing the literature on that. Cough was only in around 2/3, so it's not going to catch all of your cases. Fever was the most frequent, but again, not everybody has a fever. And the trouble with the fever is it's really tricksy. You know, you measure someone's fever and it's up one day, and then next minute it's down again. You can't distinguish who's going to have mild or moderate infection. There are some predictors, but you know, Part A, the KCL paper on symptom clusters, I still don't think you can tell exactly who's going to get severely ill or not. Anosmia is proving to be quite a good predictor for community cases, and other symptoms: shortness of breath, headache, diarrhea, runny nose, sore throat, fatigue, etc. And we're also seeing some eye symptoms and rash and that funny blue toe that you probably heard about. And getting down to the more severe end of the spectrum, I looked at the age breakdown of hospitalised cases. This was a few weeks ago, but it still holds true. And also then looked at who was in ICU, and you can see that the ICU median is much lower, so 50 to 59, whereas the median and mode for hospitalised cases is more like 70, and lots of cases in the older age groups. So there's kind of, we kind of imagine that you get sick with COVID, most people get better, some people get worse, they turn up at hospital, they're on oxygen, and then they progress maybe to ITU, and then it's a bad outcome and they die or they recover. But I think what we're seeing is for older people, that's not the way that it goes, that actually they don't end up in ICU, or they don't sometimes even end up in hospital at all, but they still have quite severe outcomes. As you can see from the next slide, which is just from our daily slides and on the website of the age sex pyramid of death reported to Public Health Wales, this is the more specific but not as sensitive reporting, so the Office for National Statistics is better for this. But this does show really that the peak of deaths is in the 80 to 89 age group. And as I say, when you look at case fatality by age, it really goes up steeply, so that it's over 10% for the over 90s. And I think it's about 5%ish for 80 to 89, but nothing like that for the younger age groups. And one of the other reasons for this terrible effect on older people is the way that it's affected care homes. So this is an output from one of the outbreaks that we had, showing really rapidly how it spreads through the whole home, through staff and resident cases. And the graph on the map on the right shows just after a couple of months of this outbreak, how much of Wales in terms of care homes was affected. I can't remember the exact percentage, but we must be pushing 60% or so of homes that have been affected. And in April, there was a prediction that if things carried on as they were in England, that we would end up with 90% of all homes affected. And that also shows that a lot of the deaths that are occurring are actually in care homes. They're those the red deaths there, so they're not even making it as far as hospital. Really disturbingly, I've heard described that, you know, and sometimes the presenting symptoms of this in the care home, sometimes it's a little bit of fatigue, sometimes it's a bit of runny nose, sometimes a bit of diarrhea, and sometimes it's sudden death. People just pass away very quickly. And just also be mindful that even though some of those deaths in the hospital might be care home residents who've made it to hospital, but then had a poor outcome. So really severe impact on older people, worse than seasonal flu. We've tried to look a bit at the data on ethnicity. This is more difficult to look at, and the take-home message from this is not so much a clear story about ethnicity, but a clear story that really nobody's been recording ethnicity in the health records anywhere properly for quite a long time. And so when they've asked the questions about this, this has uncovered the fact that we just don't have good data on this. This is a study done in CDSC where we've estimated ethnicity from people's surnames. Very problematic method, obviously. You know, this is not ideal to just assume someone's ethnicity, which should be self-reported. But we try to look at the risks of ICU and death. And actually, apart from age, the ethnicity variables didn't come out in this. Obviously, it's a small sample, but nothing particularly came out. But there are some other studies, like the intensive care one, that also find it a bit more complicated to tease anything out of the ethnicity data. There's not always a clear signal that comes out of this. But the one thing I'm prepared to say is that it's not well recorded. I thought I'd throw this in because this is one of the most difficult things, apart from face masks, I've found about this whole thing, and I've had interesting arguments with colleagues about this. You know, we've almost likened it to, if people are familiar with the Philip Pullman books, that it's a bit like dust in the books of dust, that this is something that only happens to children when they reach puberty, and before that it's completely they're completely untouched. Now that's a slightly fanciful analogy, but there is some fairly strong evidence that that's the case. Actually, young children don't seem to get this. We haven't got the reasons why. It may turn out that this receptor that that virus uses is just not so prevalent in children, and so they're not as likely to get infected. This is a really emerging story. When it first started, I was very skeptical. Everything else is spread by children. I'm sure everyone who's had or met or seen on television a child will know that they are really good sources for spreading really anything, chocolate, infections, all sorts of things. And I was really skeptical that children did not play a role in this. However, I'm starting to be convinced that they are at least at lower risk. But the trouble is, as you see from this slide, they're probably less susceptible. But the trouble is that they don't see many symptoms. So they might be walking around having it and maybe spreading it, but not knowing. And so therefore they're half as much less likely to get it, but much more likely to pass it on if they come across you. So tricky with children. And that makes the whole schools thing very tricky as well, which I know has been a really difficult debate here. They're absent from our surveillance mainly. There's hardly any in the community cases. If you go and sample the population, like with the ONS study, they didn't find any significant difference across age groups, i.e. quite a lot of the children did have COVID infection. And if you look at serology, past infection, there was again a gradient. The children were less susceptible, but they were not susceptible. So about half to 2/3 of the seropositive in adults in this big survey in Spain, which I think is really interesting. Some of the data is from modelling, so it's a bit of an estimate. And there's a lot of stuff from transmission. So when they've looked at transmission chains, you hardly ever find a child as an index. But I'm a bit skeptical. It's like, well, you wouldn't you? Because you wouldn't have found that they were an index, and you might have kept them in so they couldn't become an index. So I'm really exercised about watching out for cases, in particular things like school teachers, as we go forward. But when kids have turned up to schools, they don't seem to have spread it. But anyway, I'm just reserving judgment a bit on this. This is just to show you the impact in terms of deaths and all death compared to the 5-year average. So it did cause this really big peak in deaths over and above the seasonal average. It's now come down, fortunately, to baseline. It'll be interesting to see what happens in the coming seasons to the death curve, because there may be an element of bringing forward of deaths, but that really is quite a big increase and comparable and much more than, say, a seasonal flu. So in terms of I've done a bit of epidemiology. In terms of my experience, so I started off in January, and I was going to all the meetings, etc. But I was it felt like that modelling what was happening was something of interest. So I was frantically typing in the numbers from England and sometimes from these Chinese websites, trying to find out how many new cases in Wuhan or in China as a total, and just sticking them into simple packages and seeing how fast it spread. And the early estimates were that the sort of R number that we've all heard about was about 2. And when I was putting this in, mine was coming out at more like 3 or 4 or even 5. So I communicated it to the modelling groups, but we didn't publish it because I felt that it was based on fairly sketchy data. However, I have seen subsequently that the R number is probably north of 3, and that people have published with similar methods. It was complicated in China because people then moved out of Wuhan, so it was very difficult to see what was going on. But if you added them all up, you got, I thought, was a decent estimate. This is the challenge for surveillance, and I've just come from the incident team in Wrexham, which is looking at cases there, and this kind of shows you what our normal surveillance pyramid, and really also showing that what we get is unfortunately the tip of the iceberg. And really for this COVID, we want to get all of them, and that's really challenging because any case could find out that actually lots of people have been infected from them, and you want to try and find those cases, and I'm pretty sure that not everyone's getting tested, so you only really find out the true impact when you do a serological survey. We've tested a lot of people in Wales, but I'm pretty sure we haven't tested everyone with the infection. There's this King's College Zoe app that you might have heard of that you can enter your symptoms into, and that can give better population-based estimates. But again, it doesn't perhaps reach the parts of the population that you'd want to. So these are the levels at which you might start to count things, and we pretty much count all of these. So we're doing a lot of surveillance at the moment. Quick thing on the R number. So the R number is very simple. You've probably all read this before as public health specialists, but the R number is the number of people that one sick person will infect on average. So for things like Ebola and Hep C, it's about 2, 4 for HIV, 4 for SARS, and then up to sort of 18 for measles. When you look at how fast things spread, you then have to add in also how long it takes to give it from one person to the other. So an infection that takes a long time to incubate might have a high R number but still be slow to grow, if you see what I mean. So it's a combination of those two things. And as I was just talking about, COVID is somewhere between, I would say, 3 and 4, possibly even higher. What we know about the transmission also is quite compartmentalized. So what I've been trying to focus on is just looking at the hospitalized cases, because they're my only decent marker of cases in the community, assuming that a constant proportion of cases end up in the hospital. That's my only decent marker, because testing has changed so much in the community. You can't just look at all community cases. There's also transmission in hospital, unfortunately, and that's been evident since right at the start. And it's very challenging also because of the low levels of symptoms. The responses has included, like in Hillingdon recently, that they're just testing all of the staff every week. It can be very challenging, and then that throws up false positives. But hospitals definitely a setting. The slightly good news on that is that just because you get it in the hospital doesn't mean that your illness was as bad as if you got it in the community and then ended up in hospital because you were sick. So it really complicates the picture. So you then have to try and tease out the hospital-acquired cases from those cases that got sick in the community and then got so sick they ended up in hospital. And as I've said, care homes and other closed settings are a big risk factor. We've recently looked at hospital discharges, and we don't think that they play such a big role as people might say in the media and other reports. They don't seem to be associated with outbreaks particularly. Although that's not to say that they can't. I'm just saying in the past they haven't. So the other thing, other modelling that we were doing frantically at the beginning, this is going back to kind of February, March time, is that we knew that this big wave was coming. We could see what was happening in Italy, and there was a desperate attempt, to find out how bad it would be and what we could do about it in terms of the lockdown, which did eventually happen, and also how the NHS could plan for it. This is the original Ferguson paper, on which a lot of this is based. There's been all sorts of controversy around this, including around his membership of SAGE, etc. But I think that this is pretty good work, and it is just standard modelling. That the scary thing with this is two things. One is his original conclusion was that if you locked down hard, you could flatten the curve. However, there was no long-term strategy. So all of his lockdown hard curves have a second bigger curve further along, which you can see over there in December. It's not clear to me that anyone's found an answer to that yet. I don't wish to be disencouraging, but I'm just saying that that's just true. There is no real strategy for doing that other than locking down again, which the PM has just said is not really an option. So this will be interesting. The other thing is that the predictions, even with severe lockdown, we're getting pretty close to our full capacity in terms of hospital and ICU. So we did a lot of work adapting these numbers with a bit of lockdown and then translating them into what it would mean for the NHS in Wales and giving a kind of reasonable worst case scenario. It was much worse than actually happened. And I think people recognised that we were telling health boards that they needed, 10 times as many ICU beds as they had, and they ended up needing about 2 times as many. And that did cause a lot of problems. But I think my feeling at the time was that we needed to plan for the worst. And so that's what we did, and there was enormous amounts of work to do that, and it was really well done. And I think that the incredible response in Wales. Herd protection also goes with the Ferguson paper, also controversial. I don't think it's that controversial, to be honest. Herd protection happens with everything, every outbreak that's person to person, and there's immunity. Otherwise, they never go away. Every seasonal flu outbreak, every seasonal coronavirus, everything, it all gets up to a level whereby there's enough immunity that the infections go down. I mean, that's not absolutely everything, but it is pretty standard. Just the question is whether you think that that's a societal aim or not, but it does exist. The concept itself is not political, it's just mathematical. And the little graph on the right just shows you what happens once you get to a level where the immunity is such that one case gives rise to fewer than one other case. So it just starts to drop down as the green line goes up, which is the number of recovered people is. And we've used our data. This is just hospitalizations, if you can recall what I was saying about having to pick out just the hospitalized cases. So we use that to estimate the reproductive number over time. The early ones are going to be wrong because there were some cut-offs in the data, so there's an artificial increase, and there's also a lag of about 2 weeks. But you can see that about 2 weeks after the lockdown on the 23rd, R starts to tip below 1. So you can see that line where R equals 1, and there's been a few ups and downs, but this was, I think, up to kind of late May, and you can see it was starting to come down again. And our estimates still aren't too bad. They're still below 1 from the stuff we send in to London School. Again, right at the beginning, we've had a lot of changes in how we find COVID. At the start, it was a foreign disease, so people had it from China or somewhere in the Far East or cruises or wherever. And then it became a European disease, so it was people from Italy, although as we know now, there were also people from France and Spain and all sorts of countries, but it's quite hard to adapt. The case definition changed from being travel contact to just people who were hospitalized, and then to all symptomatic cases, and then to testing being offered to everybody who wanted the test, and then with anosmia added in. And the early lessons I found from contact tracing were firstly that not everyone was telling us about their infections, and that was very clear, and that's still a thing, I think. And that meant that rather than keeping a lockdown on it, whilst we were chasing cases from Italy, we also unfortunately saw cases from in ICU who'd not been to Italy, nor had their families been to Italy. So this kind of door metaphor is that while we were locking that door, there were people going around the side of it that we weren't picking up, and then we picked them up in hospital. And this is the other picture is from the genomics slide, the one that says I think 22 different importations or several hundred different importations into the UK, and you can see that only some of those are from Italy. There's quite a lot from Spain and France and that kind of thing. So we really did see multiple introductions from overseas, followed by amplification in the UK. So there's a lot of material here. I'm coming towards the end for those of you on a hot afternoon who are starting to kind of doze off and think, when on earth is this chap going to stop talking? So I will do, don't worry, it's only a few more slides. So the next phase of thing was really about, we really ramped up testing. So incredible efforts by our colleagues in microbiology, the testing centres, all the clinicians, self-home testing, etc. This is done before we put the Lighthouse England data in. But by the time we'd done over 200,000 tests, and there was a period in the middle where we were testing nearly twice as many per head of the population than other parts of the UK. So this was a really incredible effort, and I really, respect to my colleagues in microbiology who are working 24/7 on this. You can see there the hospital and other tested cases that the proportion of tests in the hospital has been, or the number has been fairly constant, but the positivity has gone down. So it's come down from about 50% positivity to our current is about less than 1% are positive, unless you're in particular local authorities. So there's really big increase in testing you can see there, but a fall in the actual number of cases. Trying to be a bit more hopeful now after some doom and gloom. So there's a lot of talk about, well, we need a vaccine, and then people saying, well, it's not going to work. There's never a coronavirus vaccine. There's no immunity. People can get it again, etc., etc. Well, I'm cautiously optimistic. I think that there is some immunity to coronavirus, and the slightly reductio ad absurdum argument I would use is that people don't seem to get coronavirus while they've got coronavirus. So there must be some kind of, some kind of immunity. Otherwise, it would overwhelm them and they wouldn't get better. So there must be some element of immunity. Then you're just talking about how long it lasts and whether the vaccine will do it. There's some evidence from seasonal coronaviruses that actually there is some immunity that lasts year on year, and maybe some cross reactivity between them. There's a whole bunch of vaccines. There's a long list that WHO has published now. The one we're looking at is this adenovirus one, but there's ones which are just bits of RNA. There's plasmids in liposomes and things. There's vaccines that they've inactivated. There's subunit. All of the different sorts of vaccines. I find it amazing now, actually. It's really good what can be done. This is just to show seasonal coronavirus does go up and then go down, which to me, it doesn't entirely suggest a temperature pattern. It also suggests that there's an immunity thing going on here. So I'm trying to be positive here. This is a quick diagram about the Oxford vaccine. So they took an adenovirus, like a cold virus, from a chimp. They've modified it. They've stuck in the spike protein from the outside of the coronavirus next to a really strong mammalian promoter. So as a thing that says to the cell, make lots of this, please, make lots of this protein. You jab it in someone's arm, and essentially there's a little factory in the muscle making this spike protein, and then the immune system sees the spike protein. It says, I don't like this, produces T and B cell responses and antibodies, and then 4 weeks later you can measure those antibodies, you can measure the T cells, and those antibodies also prevent the virus cells from infecting other cells in a lab model. And they've also tested this in macaques, and it protects against severe pneumonia in macaques. You might have noticed a flurry on the radio, etc. In the last few days. There was a bit of a political leak, and so things came out. But there was a lot of media interest because the first phase 1/2 results came out. They showed this good immune response from the vaccine, reasonably good safety data, and both T cell, cellular and B cell antibody responses, neutralizing antibody, which is the stuff that you want. And we've again, there's been an incredible effort by partners in Wales to recruit participants. We've done about 439, of whom I've seen quite a few personally, and we're currently following them up to see if they get coronavirus or not. It really is as simple as that. You give half of them the vaccine and half of them another vaccine, and then you just wait for the cases to come, and you count them as they come in. And that's kind of what we're doing at the moment. I was there this morning. And then they're also doing it in Brazil, the USA and South Africa, where clearly there are more cases, and they might find out whether it works sooner than we will. And there's this interesting thing at the moment as to how good would the vaccine have to be before you would want to use it. Clearly it has to be safe, but how good would it have to be? And people who know about the seasonal flu vaccine might also want to reflect on that. So that might come up in the questions. Just like coming to the end, so following from Jan's points, COVID really is a spotlight on underlying vulnerabilities, including deprivation, low paid work, the kind of work you have to go to and you can't go off sick from, the kind of work where you're packed in with other people. You know, anecdotally, we've seen people who work in a food packing factory whose partner works in a care home. This is really laid bare the issues in our society, I think, and where they are. And I think there's this statement that the society is only as strong as how well you protect the most vulnerable members. And this really is an illustration of that. You can see it in the care homes. I say the ethnicity is still unclear, but there's definitely something there. These clusters in low income, high exposure roles, there's still problems with case finding, and you can see here the difference of mortality by deprivation. So really much higher mortality in the most deprived areas compared to the least deprived. What's next? The test, trace and protect. To control transmission, we need to get all the cases reported and detect clusters, and we're working really hard to do that and doing very fine level epi to look at that, really mapping down where people's cases are. Improving syndromic surveillance, you know, the NHS direct calls and things, automating stuff. Is there going to be a second wave? Well, I think you've probably seen my views on that earlier, but note that it's already happened in several countries. And a last, possibly hopeful note on the vaccine is, regardless of whether it works or not, they are making millions of doses of it, and they are planning to use them. So watch this space, really. And this is what happened with measles. We went from, you know, up to nearly 1 million cases a year, back down to the fewer than 100 or 50 that we have now. I don't think it's going to be as good a story as this, but I just threw this in to show the power of vaccines. I'm quite prepared to eat my words when the vaccine doesn't work or something else goes wrong, but you know, I'm trying to be hopeful at the end of this presentation. So thank you very much to everyone, and I will hand back to the host. If I can do that without breaking my computer. There you go. Okay.
Thank you. Thank you, Chris. That was a really fascinating and ending a really hopeful note there on where we might go if we follow the measles line. But fascinating presentation. Thank you so much. Now we've, if anyone wants to put through any questions for Chris or Jan, please do feed them into the Q&A box. In the meantime, I've got some questions, and a few of us who've been listening in the background have had some questions for you, if that's okay. So one of the questions we've had is, are we getting any better at treating COVID as a serious illness, do you know? So we've talked a lot about prevention, but are we making progress on treatment?
Well, that's a difficult one. I'm not really qualified to answer that because I'm not being a clinician for a while. My understanding is that from speaking to the intensivists and things, that they've picked out some tips. This thing with proning, the dexamethasone. You know, they can spot people earlier who maybe need interventions, and also things like using non-invasive ventilation. So I think there is progress on that front. And actually, again, lots of research studies trying to work out what works or not. But no, I'm not really the person to ask about that. Okay,
thanks, Chris. This might be one a bit more in line, I think, with your kind of surveillance function. But we've a question here about plans for serological surveys. Are there plans for serological surveys in Wales, or testing the community?
So lots is the short answer. There's been actually an enormous effort to test a huge number of healthcare workers and some frontline workers recently, and we've got results out of that have been shared across the health boards. I think that's great, but I'm as an epidemiologist, I'm really interested in a representative sample, because what we find with the vaccine study is that people might volunteer because they think they've had COVID, so they want to get tested to see if that's what it was. And therefore you've kind of biased your sample before you've even started. Even if you do up to half of the people, that's still potentially quite a big bias, and from the other half that didn't come forward. So what we're trying to do is to do either complete groups of people or representative samples. Where we're doing that, we've already started in the Welsh Blood Service. We've taken all of their samples for a month, and we've got an age stratified sample, and that's, I say it's not published yet, but that's where that headline figure of about 6% comes in, which for me was really interesting, because the last I'd seen was about 2.5% from something from April that we'd sent across. We're also trying to do it in healthcare workers in Swansea Bay. Again, it was a bit swamped. We were looking for people to take their blood, and there wasn't anyone to take their blood. And then suddenly they took 9,000 blood samples, so we didn't really understand that. But we are working to see how we can get that done in a systematic and sort of sustainable way. We're also working with one of the police forces who were interested in doing the serological survey using the same methods, and we're also looking to do it in antenatal samples. So yeah, there's a lot of work going on in that, and that's by no means all of it.
Great, thank you. Another question we have is, are deaths being incorrectly recorded as having been caused by COVID when there may be another cause that's the real underlying cause, or how much can we trust these figures on deaths and COVID, do you think?
Gosh, well, it's the deaths are a difficult one, so I don't want to go on too much because it is quite complicated, but in terms of the Public Health Wales deaths, what we asked people to report is deaths where the clinician thinks there's been a causative factor, COVID has caused the death to some extent, and we link them back to the test to show that they have had a positive COVID test in the last 28 days, so that their first COVID positive the death is no more than 28 days from the first COVID positive test. Okay, now I know you might have seen the controversy in England that they don't have that 28 days cutoff, and actually we've got a meeting later this afternoon to discuss that. So we should be fairly specific on those if we think that those are COVID related deaths. However, that doesn't encompass all the deaths that are due to COVID, because other people might have died of it and never got tested, or wasn't suspected, or wasn't reported, etc. Plus, there were deaths where someone might have thought that it was due to it and it was tested positive, but they're not actually directly due to COVID. So I don't know if people that's listened to David Spiegelhalter, who I used to work with a little in Cambridge, he's very good on the radio, and his line consistently, which I would really support, is wait for the ONS deaths, which is what we do. We think that they're definitive, so you add up all the deaths. And as with a lot of these things, only really a time series type analysis will tell you. You just have to think about what you mean by causing to realise that it's not going to be straightforward to do that link in all cases. And sometimes you're better off using kind of statistical methods to look at what would have happened without COVID, etc.
Thank you, Chris. There's a lot of interest in the vaccine development, and you mentioned they're preparing samples, so we can expect that hopefully. When do you think that will be coming out?
Well, I've been cagey at the vaccine because Oxford are very keen, for there not to be too much media that's not directed by them. And actually, I did an interview yesterday, and then it's all closed down. However, all I'm doing now is repeating what I heard the chief executive of AstraZeneca saying on Radio 4. So I think that's in the public domain, which is that they just said that they were making it anyway, and they will have, I can't remember how many tens of millions doses by kind of August, September. And they asked him very straightforwardly, what happens if it doesn't work? And he said, we'll have to throw it away again. And it's been provided essentially free. So it's a massive gamble. The vaccine could turn out not to be safe. It could turn out not to work. It could turn out to work partly or not work in older people, which is the ones you really need it to work in. All of these things are possible. We've never produced a vaccine this quickly before. So I shouldn't be too optimistic, but I just try and be a little bit, otherwise you'd go mad, wouldn't you? Yeah.
Thank you. I just have a question here. How has the pandemic exposed differences in data and data collection between Wales and England? There's one for you.
Goodness. Yeah, I probably shouldn't answer this question at all, but
well, I think it's not just this pandemic, is it? But carry on.
So I'll start with our, a mea culpa. So we were overwhelmed at the start. We were filling in very long forms for the first cases for England. these FF100, first few 100, which were not popular and not well completed. And my experience of that was, unfortunately, essentially destroyed our ability to ask for any other forms for cases. So after that, and this is our big gap, is we do not have a systematic set of data on all of our cases. So if you get COVID, no one phones you up with a questionnaire. If you get Campylobacter, someone phones you up with a questionnaire. But if you get COVID, that does not happen. So what we did was to try and move it upstream. So we tried to add in things. So before you requested a test, you had to put in at least some basic details, and we've managed to get ethnicity in there and that kind of thing. And we've also tried to get in stuff into the test and trace program, because that's another place where people are systematically asking people questions, and that's starting to bear some fruit now. So we're starting to get some better data. Unfortunately, at the start of the test and trace, they just wanted to get a system up and running, and that was absolutely right. What they needed to get was something working, and they didn't want to hang on to it a whole load of data forms, which would be a real pain in the neck for them. I do understand that. So that limited us at the beginning, but we're now starting to get some better data, and also on hospital cases. So we're going to reintroduce the severe respiratory infection surveillance in hospitals that we were trying desperately to introduce in March, and it just didn't happen. The hospitals just said, we're too busy, we've got a wave of infections, we are not going to do this. And so that didn't happen, but we're picking that up again now at low levels, so that when it comes to the flu season, we'll at least know which people admitted have got flu and which have got COVID and where they're coming from and that kind of thing. England, they did an aggregate reporting system from the hospitals called CHESS that was quite good, that we didn't really have. Basically, it has exposed some things whereby we should probably coordinate better with the NHS in Wales. It did add some additional information, but yes, they also don't have a single data set on all their cases, and they have otherwise had to do pretty much the same stuff as us. So yeah.
Thank you. And I think one last quick question, well, I don't know if it'll be quick to answer, but the question is, you mentioned that the evidence on face masks is evolving, and just wondering what your thoughts are on their efficacy and how that evidence has changed.
Okay, so this is very much my view and not that of Public Health Wales, because I think I did it on the radio interview. I said that it was a reasonable thing to wear one, and I got told off. I think this is heading in one direction, to be honest. I've read a lot of the debate and the stuff that Trisha Greenhouse has done, which I think has been really good. And she's the absolute, we must have an RCT of people. And she's saying, actually, sometimes it doesn't work like that. At the beginning, we designated this a high consequence infection that was spread by respiratory means, and that led to all of the FFP3 and the aerosol precautions. And I do understand why we did that, but I'm not sure that in retrospect that was the best thing, because we established a kind of Ebola-like level of protection that you needed for this infection. And it gives this kind of binary, well, either you've got the full PPE or you've got nothing, and it's probably harmful. And as a public health practitioner who deals in, marginal changes, I don't think that it works like that. I think that if everybody wore a mask, the source control would reduce transmission. Yes, some people would make it worse by touching their faces and waving their masks around. There's some very odd behaviour with masks. I do appreciate that. But I'm pretty sure that it's one of these marginal benefit things, like washing your hands, that if everybody does it all the time, that actually it will have an overall effect on transmission. Now, not everybody agrees with that, and there are lots of reasons why people might not want to wear face masks, but that's my take on it anyway.
Thank you very much, Chris. That's fantastic. And I'll say thank you to you, Chris, and also to Jan. We've had great presentations from both, and really interesting discussion at the end there. We've had lots of compliments coming through, so really appreciate that. Just before we round off today's webinar, just to invite you all, if you haven't already, please do join Public Health Network Cymru. Sign up to the e-bulletins, the future webinars, and the participation you can have in that network as time goes on. Likewise, do give us suggestions for any future topics you'd like to see us cover in this webinar series. And we also have an evaluation for you, which I think the link will be up in the Q&A slot for you. Our next webinar is going to be this day next week, 29th of July at 2 p.m. We've got Liz Green and Laura Morgan from the Welsh Health Impact Assessment Support Unit, who are going to be presenting the health impact assessment of the stay-at-home policy. And we'll also be joined by Dr. Chris James, who's the Chair of Health Education Improvement Wales there. So really looking forward to that and hope you'll all join us in future. Many thanks. Oh, and one last thing, an enormous thanks to the people who've worked so hard behind the scenes to get today up and running, particularly to Andrea Parr and Angela Graves, who are back there sending me messages throughout the webinar. Thanks to everyone and to you all for joining. Diolch yn fawr. Hwyl fawr i chi.